Okay, so today we'll be discussing panoramic imaging, and this is on chapter 22 of your dental radiography textbook. We'll first start by going over the learning objectives, which are to define the key terms associated with panoramic imaging, the purpose and use of panoramic imaging, the fundamentals of this type of imaging, and the equipment used in panoramic imaging. We'll also describe patient preparation, equipment preparation, and patient positioning procedures needed before exposing a panoramic projection. We'll also describe a diagnostic panoramic image and identify the patient preparation and patient positioning errors seen on some of these images. We'll discuss the causes of these errors and describe the necessary measures needed to correct such errors. Lastly, we'll discuss the advantages and disadvantages of panoramic imaging. So it is often difficult, if not impossible, to obtain adequate diagnostic information from a series of intraoral X-ray images alone. Impacted third molar teeth, jaw fractures, and large lesions in the posterior mandible cannot be adequately examined on intraoral projections. In such cases, the panoramic image is preferred. So the purpose is to present some basic concepts of panoramic imaging and to describe the patient preparation, equipment preparation, and patient positioning procedures needed to perform this procedure. Some basic concepts includes the purpose and use of panoramic X-rays, the fundamentals, which include the rotation center and the focal trough, the equipment that's necessary, and the basic concepts. A panoramic image shows a wide view of the maxilla and the mandible and surrounding structures. So panoramic imaging is also referred to as rotational imaging, such that both the receptor and the source rotate around the patient's head, creating a series of images that are seen together to form one image. The images on a panoramic projection are not well defined or clear as an image on intraoral projections. Because of this, bite wings are often used to supplement a panoramic image used to detect dental caries or periapical lesions. And panoramic imaging is an extraoral technique that is used to examine the maxilla and the mandible on a single projection. And as described in chapter 6, an extraoral position is positioned outside the mouth during the X-ray exposure. The panoramic image provides the dental radiographer with an overall view of the maxilla and the mandible and is often used to supplement bite wings and periapical images. Images seen on the panoramic projection are not as defined or sharp as the image seen on intraoral images. So they should not be used to diagnose caries, periodontal disease, or periapical lesions. But they can be used to evaluate the dentition, which is all of the teeth. They can be used to evaluate impacted teeth and supporting structures of the dentition. They can evaluate eruption patterns, growth patterns. They can detect lesions and diseases and conditions of the jaws, and they can evaluate trauma. When intraoral images are used, such as periapical or bite wing images, the receptor and the X-ray tube remain stationary. In panoramic imaging, the receptor and the X-ray tube move around the patient. The X-ray tube rotates around the patient's head in one direction, while the receptor rotates in the opposite direction. The patient may stand or sit in a stationary position depending on the type of panoramic X-ray machine that is used, or whether the patient can stand on their own or if they're in a wheelchair. And here we can see the path of rotation that both the receptor and the source take around the patient's head. So here the receptor travels in one direction here, all around the patient's head. And the source starts from one end and it travels in this direction. The movement of the the movement of the receptor and the tube head produces an image through a process known as tomography. And with tomography, we allow imaging of one layer or section of the body while blurring images from structures another plane. In panoramic imaging, this image conforms to the shape of the dental arches. And tomography can be cut into two different words. Tomo means section, and of course, graphy just refers to the science of sectioning off these images. In panoramic imaging, the receptor and the X-ray tube head are connected and they rotate simultaneously around a patient during exposure. The pivotal point or axis around which the receptor and the X-ray tube head rotate is the rotational center. Modern panoramic X-ray units use a continuously moving center of rotation rather than multiple fixed center locations like we talked about before. In all cases, the center of rotation changes as the receptor and the tube head rotate around the patient. If we look on figure 22-4, which I have here, we can see that the center of the rotation of the X-ray source moves continuously. So even though there's tiny little pictures that the book kind of separates into separate little images, it's actually one image where the where the tube head is continuously emitting radiation onto the receptor as it rotates around the patient. The focal trough is also known as the image layer, can be defined as a three-dimensional curved zone in which the structures are clearly demonstrated on a panoramic image. The theoretical concept used to determine where the dental arches must be positioned to obtain the sharpest image is the focal trough. So the patient's jaw must be positioned in this zone in order to obtain a reasonably clear and well-defined image. So during the panoramic exposure cycle, some anatomical structures are penetrated twice by the X-ray beam because of the rotational imaging process. The location of these structures determines what type of image results, and this can be a real image, a double image, or a ghost image. A real image results when a structure lies between the receptor and moving rotation center. A real image is a true image and it appears in the correct anatomical location with varying degrees of sharpness and distortion. A double image results when an anatomical structure that is located behind the moving rotation center is penetrated twice by the X-ray beam. A double image has the same proportions as the real image and is located in the same location as the in the same location as the opposite side of the receptor. A double image appears as a mirror image or a reverse of the real image. A ghost image results when an anatomical structure or object is located outside of the focal plane and close to the X-ray source. A ghost image resembles its true image and is found on the opposite side of the receptor, such that the image appears blurred and magnified. So a ghost image appears higher than the true image as a result of the negative vertical angulation of the X-ray beam. So we'll discuss a little bit more of what these images looks like shortly here. The equipment that is going to be needed for the panoramic X-ray are the panoramic X-ray units. And if you're using an older X-ray unit that uses film, we'll need the film that's used, something called intensifying screens, and a cassette where everything is placed together. The panoramic X-ray tube head is similar to an intraoral X-ray tube head, such that each has a filament used to generate electrons and a target used to produce X-rays. A head positioner allows for the proper positioning of your patient's head such that their mid-sagittal plane is perpendicular with the floor and the Frankfurt plane is parallel with the floor. We'll go over that in a minute. And exposure controls are just the controls that are on the control panel that allow you to adjust the kVp settings, the milliamperage settings, and exposure time. And there are a number of different panoramic X-ray units available, and they all have similar components, although they may be vary just slightly. So, like I said before, the X-ray tube head is similar to the intraoral tube head. The only difference is you can't adjust the tube head on the panoramic X-ray. Okay, it's fixed. And the collimator differs from the collimator used in the intraoral X-ray tube head, such that the collimator used in the panoramic X-ray machine is a lead plate with an opening in the shape of a narrow vertical slit. The collimator in the intraoral X-ray tube head is that the tube head that you use to take X-rays in the classroom, where it's a wide circular opening. The vertical angulation of the panoramic tube head is not adjustable. It rotates behind the patient's head as the receptor rotates in front of the patient. The X-ray beam emerges from the panoramic tube head through the collimator as a narrow band. It passes through the patient and exposes the receptor through another vertical slit and the cassette carrier. The vertical angulation is fixed so that the X-ray beam is directed slightly upward, so that it's at about -10 degrees. The vertical angulation of the panoramic tube head does not change, once again, as in the case of the intraoral tube head. And the head positioner is a chin rest with a notched bite block, a forehead rest, and lateral head support or guides that is used to align the patient's teeth as accurately as possible. So when the chin rest and bite block are used, they are used to stabilize the patient's dentition in the anterior posterior direction. So you have to make sure that your patient is biting with their teeth edge to edge, or excuse me, with their anterior teeth edge to edge into that notched bite block. Their forehead should be placed against the forehead rest, and the lateral support should be guided so that they touch the patient's sides of their head. Here we can see a model of a more modern X-ray machine, or a more modern panoramic X-ray machine. Here we have a head positioner that is adjustable. So with this type of machine, you would first ask your patient to bite on this yellow bite block here, and you want them to bite with their anterior teeth edge to edge. So that means they're not biting in their normal occlusion, but they're biting such that both of their anterior teeth come together in that notch in the bite block. Next, we have our head positioners that are adjustable on this model. With the push of a button, they can close around your patient's head, securing it in a center position. Okay, and it's really hard to see in this picture here, but there is a little red laser that runs from this area of the panoramic machine, and it runs horizontal. And so this runs across the Frankfurt line. And the Frankfurt line is this imaginary line from the top of your patient's nose to the top of their ear. And this should be in a completely horizontal line such that it's parallel with the floor. The suggested exposure factors for milliamperage and kilovoltage are provided by the manufacturer and can be varied to accommodate patients of different sizes. So a patient that is a little bit smaller, like a small child, would use exposure factor settings that are less than a large patient, like a grown man, where the density of his bone and surrounding structures is going to be greater and thus require more milliamperage and or kilovoltage. Exposure time can also be adjusted based on the type of image obtained. The panoramic imaging exposure time varies depending on the receptor and the X-ray unit, but typically ranges anywhere from 10 to 30 seconds. In panoramic X-ray units, the image receptor may be a direct digital sensor or a PSP or phosphor plate or film. With digital imaging, imaging software downloads the patient information within seconds and can transmit the image to various computer workstations within the dental office. And if you are using an older system or an older machine where screen is used, a screen film is used in panoramic imaging, and we'll have to remember that it's sensitive to light from an intensifying screen. So intensifying screens are two screens that are placed on either side of the film, and the whole thing is placed inside of a cassette holder. And whatever type of receptor that's being used, whether it's a digital sensor or a film receptor, the image must clearly indicate the patient's right and or left sides. So this is kind of the same slide here, but also wanted to point out that the film used in panoramic imaging is available in two sizes. It's usually a 5x12 or a 6x12. Two basic types of intensifying screens are used: calcium tungstate and rare earth. Calcium tungstate screens emit blue light, and the rare earth screens emit green light. Rare earth screens require less X-ray exposure than do calcium tungstate screens and are considered faster. So therefore, rare earth screens are recommended in panoramic imaging because of less radiation exposure to the patient. A cassette is a device that is used to hold the extraoral film and intensifying screens together. The cassette may be rigid or flexible, curved or straight, depending on the panoramic X-ray unit. All cassettes must be light tight to protect the film from light exposure. One intensifying screen is placed on each side of the film and held in place when the cassette is closed. If the cassette is not labeled before exposure, the film must be labeled immediately after processing using a pen or adhesive label. And what I mean by this is you have to mark the patient's right and left sides because the panoramic film doesn't have a little bump on it like we are used to with intraoral films. So when the film comes out, it's sometimes difficult to distinguish the left and the right side of the patient. So if this isn't marked before the X-ray is exposed somehow, like by putting a little marker on the film, this should be marked after with a pen or some type of label. Some step-by-step procedures include equipment preparation, patient preparation, and patient positioning. And just a note, and to remind you all that before exposing before exposing a panoramic receptor, infection control procedures must be adhered to. So to prepare your equipment, first you want to prepare the receptor. If you're using film, load the panoramic cassette in the dark room under safe light conditions before bringing it out to the X-ray unit. Then place one extraoral film, this will include placing one extraoral film and two intensifying screens in the cassette and securely closing it. And then we want to prepare the bite block. Make sure you cover the bite block with some type of plastic barrier before you ask the patient to bite on it. If it's not covered with any material, it must be sterilized in between patients. Next, you want to choose your exposure settings, and you want to set the exposure factors like kilovoltage or milliamperage or time according to not only the manufacturer's recommendation, but also the size of the patient. Next, adjust the machine height such that it accommodates the height of the patient and align all movable parts. So the dental radiographer must complete the panoramic imaging equipment preparations before placing the patient for exposure. Okay, you never want to ask your patient to bite on something that is unprepared or to adjust the height of the machine while your patient is biting down on the bite block. This can cause injury or discomfort to your patient. So after preparing the panoramic X-ray unit, the dental radiographer must prepare the patient for the procedure. And the patient, and this includes explaining the imaging procedures to your patient, placing the lead apron without a thyroid collar on the patient and secure it. And you usually want to use a double-sided lead apron to cover both your patient's back and the front of them. And then also ask your patients to remove all of the objects on their head. This will include eyeglasses, earrings, intraoral and extraoral piercings, necklaces, napkin chains, hearing aids, hairpins, barrettes, or any other oral prosthesis or anything that will get in the way of the X-ray, anything metal. Next, you want to instruct the patient to sit or stand as tall as possible with their back being straight and erect. Next, ask the patient to bite on the plastic bite block such that their teeth are biting edge to edge inside the little groove on the bite block. You want to position the mid-sagittal plane perpendicular to the floor. And again, the mid-sagittal plane refers to the midline, or that vertical line that runs in between their forehead, their nose, and their chin, which divides their face in half. So if you refer to procedure 22-3, we can go over patient positioning a little better, or you can kind of visualize what this looks like. Okay, so first position the Frankfurt plane parallel with the floor. And the Frankfurt plane is, I'm going to jump to this slide really quick so I can show you. So here's what this looks like. And the Frankfurt plane is this line here that runs horizontally that connects the patient's tip of the nose to the top of their ear. Okay, next we want to instruct the patient to close the lips around the bite block. Also, you want to ask them to touch the roof of their mouth with their tongue after they swallow. So ask them to swallow and then at the same time touch the roof of their mouth with their tongue. Okay, and then instruct the patient to remain still while the machine is rotating during exposure. Then go ahead and expose the receptor and proceed with receptor processing. So here's that image again. On the left side, You just want to make sure that the patient places their teeth in that little groove in the bite block. So they should be biting edge to edge with their anterior teeth in that little groove. If you're using an older machine, it will have a chin rest that looks like this. If you're using a newer machine, it will not have a chin rest, but it will have that laser beam that establishes that Frankfurt plane that is seen here in an older machine. Okay, then you want to make sure that you have that mid-sagittal line, which is this line here that runs vertically between their forehead, between their eyes, the tip of their nose, and the tip of their chin. That should be perpendicular with the floor, and it should run across these areas here. It should not go, it should not go in between the eyeball or anything on the side of the face. Remember, the mid-sagittal plane always runs vertically to divide their face in half. A diagnostic panoramic image results when the equipment preparation, patient preparation, and patient positioning are completed correctly. The ideal panoramic image should be free from all errors in exposure, technique, and positioning. Such an image is not always possible. Okay, so there are minor errors that may be present that don't necessarily affect the diagnostic quality of the image. And if this is the case, those don't need to be retaken. A diagnostic panoramic image must demonstrate accurate anatomic features and proper exposure, resulting in correct density and contrast. A panoramic image must allow for the visualization of the maxillofacial anatomic features that it represents. Each panoramic X-ray should be assessed to determine if the dentition and bones of the maxillofacial region are representative. The diagnostic panoramic image results from adequate exposure and exhibits proper density and contrast. Adequate exposure results from choosing the correct kilovoltage and milliamperage settings for the size of the patient. Smaller patients require less exposure, whereas larger patients require more. And with an ideal panoramic image, the density or overall darkness is not excessive. So proper contrast on a panoramic image is critical, and you should allow for the identification of the junction between the enamel and dentin in the molar region. Okay, and the reason for proper contrast is with the panoramic X-ray image, the way that this image is taken is we have multiple images that are seen together to form one image. And the panoramic unit is designed to blur out this type of overlapping of image that occurs when it tries to seam the images together. So if you have proper contrast, we shouldn't see any of those overlapping images. It should be just one ideal or one clear image or true image of what you want to see. And so inadequate contrast may lead to problems with the detection of unerupted or impacted teeth, just because it's too hard to see with multiple overlapping images. Okay, here we have some examples of exposure problems. On this, the top upper left screen, we see an example of an overexposed panoramic images, an overexposed panoramic image. Here we can see lots of dark lines or lots of dark shaded areas. It kind of almost blocks out the middle of these teeth here. It has good contrast because it's got lots of exposure, but that overexposure can lead to problems with diagnosing lesions in the bone or other things like that. The bottom or the lower right image shows an underexposed panoramic image. Okay, and here we have what looks like to be a lighter image than this one. And the lighter image, the problems that are associated with that is that a lot of the times you have some some glowing light that seems to radiate from like these areas here. And sometimes they can impede the dentist's ability to be able to see lesions below the apices of these teeth here. Okay, some common errors include patient preparation and patient positioning. And to produce a diagnostic panoramic image and minimize patient's exposure, mistakes need or should be avoided. When you have patient preparation error, or when you fail to properly prepare your patient, you can have ghost images and you can have lead apron artifacts. A ghost image is just an image artifact seen on a panoramic image that is produced when a metallic or dense object is penetrated twice by the X-ray beam. It is usually found on the opposite side of the receptor, and it appears as an indistinct, larger, and oftentimes higher than the actual counterpart. So what causes a ghost image is failure to remove radiodense objects like earrings, dentures, hearing aids, or piercings, or other objects like that. And the problem occurs, like I said, when these radiodense objects are not removed. And the solution is, as the dental radiographer, you must instruct the patient to remove all radiodense objects in the head and neck region prior to positioning the patient. So if we look on page 252 on figures 22-19, we can see an example of what a ghost image looks like as a result of the patient not removing their earrings. There's some little annotations on that picture. The number 1 represents the earrings on the patient's lower right ear, and number 2 indicates what that ghost image looks like for that specific earring on that right side. So it appears higher, a little bit higher on the image than the actual object does. And it'll appear magnified and a little bit more blurry, almost like a ghost of what the actual earring looks like. Okay, a lead apron artifact is a problem that happens when a radiopaque cone-shaped artifact that obscures diagnostic information results. This all results if the lead apron is incorrectly placed, or if you're using a lead apron with a thyroid collar. So this is just another reason why we don't use a thyroid collar with panoramic x-rays, is because a lot of the times that thyroid collar can get in the way of the primary beam. And as we all know, the lead apron prevents any x-ray beams from penetrating through it. So that would mean that it wouldn't get to the actual receptor. And the solution is to always make sure you use a lead apron without a thyroid collar when you're exposing a panoramic projection. So if this happens and you're still getting, if this happens even though you're still not using a thyroid collar, you can just position the lead apron so it's lower around the patient's neck. Okay, some positioning errors occur because the panoramic image does not show the fine anatomic details seen on an intraoral radiographs. And even the smallest patient positioning error can create a distorted image. So this can include the positioning of the lips and tongue. If you have the patient with their chin tipped up or down, or if the teeth are in front of the focal point, or if they're behind the focal trough, or if the head is turned, or if your patient is in a slumped posture. So positioning of the lips and tongue is a problem if the patient lips are not closed on a bite block during the exposure of a panoramic projection, such that a dark radiolucent shadow results and it obscures the anterior teeth. And if the tongue is not in contact with the palate during exposure of the panoramic projection, a dark radiolucent shadow results that obscures the apices of the maxillary teeth. And a solution or a way to prevent this is to make sure you instruct the patient to close the lips around the bite block and to swallow and raise the tongue up to the palate during the exposure of the receptor. Okay, chin tipped up is a problem that happens if the patient's chin is positioned too high, and it gives us a reverse smile line that is apparent on the image. So a way we can prevent this is to make sure that the patient's Frankfurt plane is parallel with the floor. Okay, we can see an example of what this looks like on the following slide. Let's see. Here we go. So in this picture, we have the patient's chin that is tipped too far up. So we can see that it looks like almost like the patient is frowning, or we give like this kind of upside down smile on the image. And if we kind of look at only half of the image here and only look at maybe this left half, we can kind of see what the patient's profile look like. So we have their chin, their teeth, their nose up here, and we can kind of notice that the chin is positioned slightly upward or above the line that would normally make their occlusal plane level with the floor. Chin tip down is a problem that happens if the patient's chin is positioned too low or is tipped down, and it gives us something that looks like an exaggerated smile line on the image. So we can think of, it almost looks like a jack-o'-lantern on a pumpkin, just a really exaggerated smile. And we can see a picture of what that looks like on, let's see, on page 254, there's a little helpful hint where the Frankfurt plane is tipped down. We can see some examples of that. It almost looks like the panoramic image is giving a ridiculously huge smile. And if, again, on those images, if we only look at half of the image such that we're looking at the patient's profile, we can clearly see that the patient's chin is tipped down. Teeth anterior to the focal trough is a problem that happens if the patient's teeth are positioned too far forward on the bite block or anterior to the focal trough. And then the teeth will look like they're skinny and out of focus. The solution to this is to position the patient so that their anterior teeth are placed in an end-to-end position in that groove on the bite block. So if we look on page 236 on figures 22-15, 22-5, so this is in the beginning of the chapter, we can see a picture of what that focal trough looks like. So you can see that it almost looks like you can imagine a little tank of water where the water, of course, would be level with the floor. And so we have to make sure that that focal trough or your patient's mandible is positioned in that area. So this is that imaginary curved space that's shaped like a horseshoe. Teeth posterior to the focal trough is a problem if the patient's teeth are positioned too far back on the bite block or too far posterior to the focal trough. In this type of image, the anterior will appear as if they are fat and out of focus. And the solution, again, is to make sure that your patient's anterior teeth are placed in the end-to-end position in the groove on the bite block. A head turned is a problem that happens when your patient's head is not completely centered and the ramus of the posterior teeth appear unequally magnified on the panoramic image. So this is the side that's farthest from the receptor, appears magnified. The solution is to position the patient's head so that that mid-sagittal plane or that line that's given from the X-ray unit is perpendicular to the floor, while the midline is centered on the bite block. So always make sure that that mid-sagittal line runs through in between their head, in between their eyes, runs through the tip of their nose and through the tip of their chin. And we want to make sure that that vertical plane is perpendicular with the floor. A slumped posture is a problem if the patient is not standing or sitting with a straight spine, such that the cervical spine appears as a radiopacity in the center of the receptor and obscures a diagnostic information. So it'll look like you'll see a ghost image of that spine that's right in the center of your image, or something that superimposes the mid-sagittal plane. That's not something that we want to see in an image. And to prevent this from happening, we want to instruct the patient to stand or sit as tall as possible with a straight back. So we always want the patients to be to be standing for a panoramic image. But if they can't stand for some reason, like they're in a wheelchair, we want them to sit as tall as possible with a straight back. Okay, so as with all radiographic techniques, panoramic imaging has both advantages and disadvantages. And some of the advantages include field size. And the panoramic image covers the entire maxilla and mandible, and more anatomic structures can be viewed on a panoramic image than with a complete mouth series. In addition, lesions and conditions of the jaws that may not be seen on an intraoral X-ray image can be detected on a panoramic image. Also, simplicity. So the exposure of a panoramic receptor is relatively simple and requires minimal amounts of time and training for dental radiography. So there's not a lot of technique sensitivity with taking a panoramic X-ray like there is taking an intraoral X-ray. Also, patient cooperation is another advantage. The exposure of a panoramic image is more acceptable to the patient because no discomfort is involved. For example, children who cannot tolerate intraoral projections may find it easier to sit still during the exposure of a panoramic image. Also, we have minimal exposure. The panoramic image involves only minimal radiation exposure of the patient. Okay, some disadvantages are image quality, because images seen on a panoramic image are not as sharp as images produced with intraoral projections. As a result, the panoramic image cannot be used to diagnose dental caries, periodontal disease, or periapical lesions. Also, there is some focal trough limitations. So objects of interest that are located outside of the focal trough cannot be seen. So if your patient is unable to position their head in that focal trough because of some physical limitations, that we won't be able to see what's outside of that focal trough. Also, distortion is another consideration because certain amounts of magnification, distortion, and overlapping are present on a panoramic image, even when proper technique is used. Also, equipment costs. The cost of a panoramic X-ray unit is relatively high compared with the cost of an intraoral X-ray unit. Okay, that's all I have for this chapter. If you have any questions, feel free to email me or, of course, ask me in class. Thanks a lot for listening. We'll talk next time.